Welcome to the second part of this lecture on co-occurring disorders. In this part, we are going to take a look at a basic understanding of what mental health is. So some basic concepts to keep in mind is that everyone experiences symptoms of mental health issues. So life circumstances and changes that happen can cause distress in our lives that result in certain mental health symptoms, maybe feelings of depression or anxiety or others. I think it's important to keep in mind with kind of thinking through the lens of language that we use. A lot of times when the phrase mental health comes up, it's maybe has kind of a negative connotation to it, that we're saying it in reference to a disease or disorder. And so when we talk about mental health, a lot of time we're talking about really a lack of mental health, there being the presence of depression or anxiety or these other disorders. However, I do like to keep in mind this definition from the World Health Organization, which frames the phrase of mental health in kind of a more positive way. And so they define mental health as a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. So really, in talking about mental health, we want to be talking about that wellness that is described here. So that positive state of well-being, that positive state of health. And so I think that's important to distinguish, because when we're talking about these more debilitating conditions regarding mental health, I don't want that to take away from the idea of kind of, I guess, the wellness aspect of it, that we're all kind of seeking to have more mental health in our lives, just as we're seeking to be more physically healthy in our lives, that there's things that we can do and steps that we can take to become more well in our body and minds and spirits. And so I just kind of want to put that out there to kind of keep in the back of our minds as well. And so thinking about the idea that mental stresses affect everyone, we can kind of think of this in two different ways, that there's going to be kind of this normal in the sense that it's something that everyone's going to experience, a normal state of mental distress, and then kind of a more, I don't necessarily want to say advanced, but also kind of in a way a more advanced state of a mental disorder. And so we'll look at the differences between those two. So the idea of mental distress is common. It's a response to environmental challenges. So throughout our lives, obviously, we're all going to experience challenges, whether it's in our jobs or our families, our physical health, whatever it may be. We're going to go through things that are going to have a negative effect on our mental health. They may be short-term and not as severe. They usually don't cause a significant impairment in functioning, meaning that they might not cause a significant effect on whether or not we can get through our day-to-day. It might not necessarily affect our ability to go to work or to go to school, at least not in significant long-term ways. So these are things that shouldn't be diagnosed. It's a part of the human experience that we're going to experience some mental distresses throughout our life. It usually doesn't require professional intervention, and usually responds well to kind of the everyday supports that we have in place, or making positive lifestyle choices and engaging in positive activities as ways to deal with and cope with this mental distress that we're experiencing. Different than that, though, are mental disorders, and this is more what we're talking about when we are looking at diagnoses that are made specifically around mental illness. And so these are less common than mental distresses. They frequently will begin without environmental challenges. So that may be because of something that's going on with the structure of the brain, that maybe someone is experiencing depression, not necessarily because of what's going on in their day-to-day life. These disorders are going to be much more long-term, and they likely will cause a significant functional impairment. So they must meet recognized diagnostic criteria. Mostly what we're using here is the DSM, currently the 5th edition, and we're going to take a look at that a little bit more later. And these disorders typically do require professional intervention, so seeing a therapist or a psychiatrist, maybe getting on some medication to assist, those kinds of things. They can definitely respond well to evidence-based treatments, and they will also be helped by appropriate supports and positive lifestyle activities. So mostly when we're talking about co-occurring disorders, we're talking about the kind of this idea of a mental health disorder as well as a substance use disorder. However, I do think it's also important to keep in mind that the day-to-day distress or the every once in a while distress that people may be experiencing can also contribute to substance use as a way to cope with those distresses. So I think that definitely can influence substance use, but at the same time, for kind of the context of addressing co-occurring disorders, we are thinking more about diagnosed disorders that meet these diagnostic criteria set forward in the DSM-5. So that's just something to keep in mind. So a few concepts I wanted to define was any mental illness and serious mental illness. And so any mental illness is this broad overall concept of a mental, behavioral, or mental disorder that's going to affect someone from a mild up to severe impairment. So it's kind of including all of that, mild, moderate, and severe impairment. However, with a serious mental illness, you're specifically looking at those mental, behavioral, or emotional disorders that have caused that severe impairment. And so when we say the phrase serious mental illness, it's not referring to bipolar disorder as a more serious mental illness than anxiety disorder. It's not that, it's that either of those disorders or any disorder is causing a serious functional impairment. And by functional impairment, we're talking about someone's ability to do the things they need to do. So essentially, is it affecting their ability to get to work or to perform well in their job or going to school, or is it impairing their relationships with other people? Those are what we mean when we are referring to these functional impairments. And for some people, the mental illness may be causing such a severe impairment that they're not able to get themselves food or get themselves clothing. That's kind of what fits under the idea of a grave disability under the 5150 code, is that a mental illness is causing such a severe impact on this person's life that they can't do the basic things they need to do to keep themselves alive. And that's kind of the extreme end of it. But again, with serious mental illness, we are thinking about how is someone's life being affected by this mental illness, and is it interfering with their ability to get those things done that need to be done. And so this is something that we'll keep in mind when we get to our section on the DSM-5. Another thing to keep in mind is that mental illness and mental well-being are not necessarily the same thing. So in this graphic here, we have kind of another 4-quadrant system set up. And so this brings up the idea that someone's mental well-being can still be positive even though they have a mental illness. So we can look at these 4 different quadrants. So in the first one, on the top left, if someone was in that quadrant, it would be that they are experiencing a high level of mental well-being despite being diagnosed with a mental illness. So that's the idea that they have this specific mental illness. It's going to create some challenges in their life, but it's not at the level of affecting their mental well-being overall, or it will, of course, to some degree, but they can still maintain a high level of mental well-being. So that's an example of there not being a significant functional impairment. If we go over to the right on the top, in that quadrant, a person would be experiencing a high level of mental well-being and they have no mental illness. Then if we go to the bottom left, in this quadrant, we have a person experiencing mental illness who has a low level of mental well-being. And then to the right, we have a person who has no diagnosable mental illness who has a low level of mental well-being. So mental well-being and mental illnesses are not necessarily always going to influence each other. You might have a mental illness but have a high mental well-being, but then at the same time you may not have any diagnosable mental illness, but you still have a low level of mental well-being. And so that can be, again, an important thing to keep in mind. And again, that's kind of was part of our discussion on distress versus disorder, that both those things, these having a low mental well-being, regardless of whether or not there's a mental illness, that can still impact someone's decision to use substances, especially if it's something that they're using to cope. So, when we are looking at specific disorders, we have a process for diagnosing those, and that of course is using the DSM, currently in the 5th edition. And so the idea here is that the diagnoses in the DSM identify specific clusters of symptoms that can cause significant impairment in occupational, social, and other important areas of functioning. So a question posed here that you can think about, maybe pause the video and jot down some ideas on this, is why diagnose? Why do we have this system set up for diagnosing? So this is kind of just a broad overview of some different categories within the DSM-5. So you're going to have specific criteria for each of these disorders, but I thought it might be helpful to point out how these disorders are grouped together. So it's kind of like certain ones are maybe in the same family, they're closely related. So for example, we have anxiety disorders, and so this covers diagnoses such as generalized anxiety disorder, panic disorder, and social anxiety disorder. We have depressive disorders, and this includes major depressive disorder and persistent depressive disorder. We have bipolar and related disorders. That would be bipolar 1, bipolar 2 diagnoses. We have the schizophrenia spectrum and other psychotic disorders. So this would include schizophrenia, brief psychotic disorder, and schizoaffective disorder. We also have personality disorders, and so this can include antisocial personality disorder, narcissistic personality disorder, and borderline personality. There's trauma and stressor-related disorders, so this is PTSD, adjustment disorder, reactive attachment disorder. And then substance use disorders are also in the DSM-5, as we talked about in one of our previous lectures. And so that's dependent on what substance is being used, and so there's different criteria for those. And then there's also neurodevelopmental disorders, so ADHD, autism, specific learning disorders. And these are just some examples from each of those categories. It's not necessarily comprehensive. I know if any of you have seen the DSM-5, you know that it is a very big book, so there's a lot of information and a lot of diagnoses in those. And just one thing to point out, though I will talk about it more in our next slide, is that also within the DSM-5 is these specific diagnoses for a substance or medication-induced blank disorder. So it may be the case that someone is presenting signs of an anxiety disorder. However, what may be gleaned from the assessment is that that anxiety disorder is specifically being caused by a substance that's being used or a medication that's being used. And so in a situation like that, the person would be given a diagnosis of a substance-induced anxiety disorder. So let's talk more about that in our next slide. And so a few notes about symptoms. One is that symptoms can change and subside over time. So maybe someone's experiencing a specific symptom in the early stages of their depression, but that changes over time and isn't as prevalent anymore, or maybe a new symptom begins to emerge. So it is important to keep in mind that the symptoms specific to a diagnosis can change and subside over time. Another thing to keep in mind is that psychiatric symptoms and the negative effects of using a substance can overlap with each other, and those signs and symptoms can mimic each other. And so that's what we're talking about when we talk about substance-induced disorders, is that they can show the same symptoms and signs as other psychiatric disorders. So for example, someone may be presenting with anxiety, and so that could be because of a generalized anxiety disorder, but it also could be being caused and induced because of a substance that they're using. So because of that, it is important to, before making a diagnosis or starting someone on a psychiatric medication, it is recommended that about 30 to 60 days of continuous clean time is present. And that's because you want to kind of separate out whether or not these symptoms are because of a psychiatric disorder or because of a substance that's being used. So again, if that anxiety is being caused because of a specific substance, you might not necessarily want to give that diagnosis of generalized anxiety disorder or start them on a medication for that. However, we do know that that timeline may not always be ideal for someone. They definitely do need to get started on a treatment for a psychiatric disorder much more sooner than those 1 or 2 months. And so definitely when you are able to have a previous history of the mental illness, especially without that substance being used, then that's a good indication that this mental health disorder has been present before. It definitely is something that's happening organically in the brain. It's not being caused because of a substance. And so getting started on that treatment more quickly would be recommended. So that's something that a psychiatrist kind of has to assess and think about when they're making these diagnoses. And so here's just a little chart to show how substance use can mimic certain disorders. So it'll give you the substance on the left, and then kind of the symptom there in the middle, and then what psychiatric disorder that has in common with on the right-hand side. So for example, in that first line, alcohol can cause depression and anxiety, and of course, I guess I moved slides, but of course that those signs of depression and anxiety can also be seen in mood disorders like depression, or anxiety disorders like social anxiety or generalized anxiety. So I can't go back on the slide without messing up my recording of the audio, but if you want to pause and rewind a little bit to look back at that slide, definitely feel free to do so. So I did want to give one specific example of a diagnosis from the DSM-5. So this is kind of the exact text that we would see in the DSM-5 for the criteria of diagnosing a persistent depressive disorder. So we'll look through that criteria so you can kind of see what that might look like. So you can see the different criteria are lettered A through H, and so the person has to meet the criteria for all these things. So the first criteria would be that they're experiencing a depressed mood for most of the day, for more days than not, as indicated by either subjective account or observation by others for at least 2 years. And then there's just a note that for children and adolescents, the mood can be irritable and the duration can be less than a year. So if you're a clinician assessing this, in your assessment, you're really kind of focusing on teasing out some of this information and figuring out, getting a timeline. Has this been occurring for 2 years or more? Are these feelings of depression present for most of the day, for more days than not? The second criteria is that while they're depressed and feeling that depression, there would be at least 2 or more of the following symptoms. So again, you're going to be asking your questions to figure out if any of these signs are going on. And so if they have 2 or more of these, then they'll have considered to meet this criteria. And so those are poor appetite or overeating, insomnia or hypersomnia, so not sleeping a lot or sleeping a lot, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and feelings of hopelessness. So again, if they're showing at least 2 of those, they would meet criteria B. Criteria C is that during the 2-year period, or 1 year for children or adolescents, the individual has never been without the symptoms of criteria A and B for more than 2 months at a time. So maybe one thing to point out is that this is specific to the diagnosis of persistent depressive disorder, while there's other diagnoses in the DSM-5 regarding depression that don't have these long timelines on them. So if you're assessing someone that is showing signs of depression, you're kind of thinking about if this timeline is present, that it's really sustained, it's been over 2 years, there's not a relief in the symptom for any more than 2 months, then you're thinking about a diagnosis of persistent depressive disorders. Whereas if there's not that timeline there, you can kind of look at a different depressive disorder and see if that shorter timeline fits under those other disorders. So that's just a quick note about that. Criteria D is that for a major depressive disorder must be continuously present for 2 years. E, there has never been a manic episode or a hypermanic episode, and criteria have not been met for cyclothymic disorder. So this is the kind of idea of you're ruling out other things. So if someone is experiencing depression, but they've also had a manic or a hypomanic episode, that puts them in the range of a bipolar 1 or bipolar 2 disorder diagnosis. And so this is just kind of a reminder for the clinician who's assessing to make sure that they're also ruling out these other diagnoses. So if there has been a manic episode, they're not going to fit the criteria for persistent depressive disorder anymore. You're going to be shifting to looking at a diagnosis for bipolar 1 disorder. Criteria F, the disturbance is not better explained by persistent schizoaffective disorder, schizophrenia, delusional disorder, or other disorders on the schizophrenia spectrum. Again, so you're ruling out these other diagnoses. G, the symptoms are not attributable to the physiological effects of a substance or another medical condition. So again, we're ruling out the other possible causes. So if there's an indication or a sign that maybe a substance they're using is causing these depressive symptoms, or a physical condition that they're experiencing is causing these depressive symptoms, or the sleeping all day, for example, or the overeating or not eating enough, then if that's true, then you're not making this diagnosis of persistent depressive disorder. Then in that case, you're referring to a physician that can make a diagnosis and figure out what's going on with the medical condition. Or you're thinking about the substance that's being used, and is there maybe a substance use disorder present, or a way that the substance is inducing those depressive symptoms. And then the last criteria, and this is a criteria you'll see throughout the DSM on these different disorders, and again, this is what we've talked about earlier as what specifically makes a mental health issue a mental health disorder is that those symptoms are causing significant distress or impairment. So they're not able to accomplish or perform well in these different important areas of life, like social, occupational. So that's kind of referring to work or school, or any other of those things that would make it difficult to really get the day-to-day things done. So that's just a basic overview of one diagnostic criteria from the DSM-5, just so you can kind of get an idea of what those criteria might look like, or the flow of how that's put together. And that mostly wraps up our discussion on co-occurring disorders. I just wanted to point out that for this week's discussion, you will be looking at a case study of a young woman named Jane. And you'll see in the case study, as it describes, that kind of the main thing that you're looking at with this exercise is kind of what we've been talking about, is can you look at these symptoms and figure out and assess if they are because of a mental health disorder or if they're because of an influence of a substance that's being used. Again, in assessing, it's important to make sure that we're figuring out whether or not those symptoms are overlapping and being caused by one or the other. So it is important to kind of tease those out. So in this case study, you're kind of looking through it through that lens and seeing what's really going on with Jane. Are these mental health symptoms because of a psychiatric disorder or because of substance use? And so the discussion explains that all more in detail, but I just wanted to put that out there as what you'll be doing this week for the discussion. All right, thank you for listening, and I hope you all have a good one.